Daktari, village surgeon.
A quick one.
A quick one.
Peri-urban surgeon.
So this village surgeon quickly moves
Yes.
to now peri-urban, umesema. What inspired you to make the transition? Uliboeka na village, but you mentioned something very important, which we will come to. The wife supported you and gave you the idea.
Yes.
So did she say, hii mambo ya village pia imechosha bana?
No necessarily. I also made a decision because when I started out in the village, I was a bachelor. And now as my contract was running out, I was a married man with a kid. And my wife works in Nairobi. So it would be commuting on Monday morning to Meru and putting up there until Friday evening, then I come home. So it was quite a stretch.
Yeah.
And therefore, I consciously really didn't want to remain there for the purpose of being close to family. So I took that option, and along the way, nature conspired and Kikuyu chance opened up. Yes.
So you're not coming to Kikuyu as just a surgeon? You came as a surgeon then, because you said you're the medical officer in charge. Chief medical officer.
Yes, chief medical officer. No, I actually interviewed. The position that was advertised for was the position of a chief medical officer with an inclination to get someone who has a surgical
so it was
background, so that then you could support a certain clinical aspect that was also needed on top of the administrative aspect. So I took the position of chief medical officer. When I was in Meru, I had interviewed initially just as a surgeon, but as I took the position, I was given the administrative duties of the founding director of medical services for the institution. It was a level 4, we pushed it to a level 5. It wasn't an internship center, we pushed it to an internship center.
Is this Kikuyu?
No, that time was in Meru. We pushed it to an internship center.
Wait, were you in management as well at that time?
Yes, I interviewed as a consultant surgeon, but when I took position, because now I was the only resident consultant in the hospital, I was offered a JD that had a management role as a director of medical services. And then over time, we eventually grew. By the time I left, to were full-time resident consultant. So each discipline has their consultant. We had moved from a level 4 to a level 5. We had gotten from just a hospital to a training hospital and a internship center, medical interns. We already had the clinical officer interns. We had opened a cancer center, an oncology center that was already licensed by the NCI and NHIF. So we had made
more resident consultants.
We had made leaps and bounds, and we were in the process of registering for COSEXA residency and all that.
That's in a span of how long?
That was I was there for 3 years. The contract was 3 years. So there was quite some improvement.
Okay.
I would say I did. I and our team. All that happened. All that happened in 3 years. Yes. And of course, they have a lot of potential. And I left my colleague there, Dr. Nixon, and he's doing a great job at that. So as I was well committed that I am not renewing my contract because of this commitment, then I was asking myself, where do I go to next? At some point, I just wanted to sleep. I remember telling the CEO,
you're tired.
You remember Obama before he left the presidency, when he was interviewed and asked, what will you do the moment you leave White House? He said, for the first 3 months, I would just sleep. And I resonated because that was the time I was also clearing residence. Like sometimes you work so hard, you wonder, what does it feel like to just sleep and wake up late, like at 9 a.m.?
There's nothing you're doing.
Like, what's this?
There's nothing on your
What
mind.
does it mean to even leave the phone switched off, without fearing,
somebody would
work
call,
would call, or family would call, because both of them are away and you are needed. So that was what was on my mind. I managed to sleep in April. I was in between jobs, and then in May I joined Kikuyu. So the position interviewed in Kikuyu was for the chief medical officer, but these had clinical duties and administrative duties. So I have been there. So I have been there now. I will be clocking 2 years this May, and next year I will be clocking 3 years.
Amazing.
Yeah.
So you're quite the leader.
I don't know what quite the leader means.
I mean, your experience, especially, Kikuyu, first of all, is not a small hospital. PCEA Kikuyu. Remember going there as a child had an eye problem. It was really known for eyes.
No, it's
back in the
absolutely
day.
a big institution, ISO certified, so the ISO processes are there. I feel like if you can run Kikuyu, you can run any
Exactly.
parastatal in the country. Is we project like 1.5 billion turnover in revenue in our projections. It's over a century old in terms of age, and it's got a robustness. It's got 4 units in one, 4 semi-autonomous units in one. I unit, which is the flagship service in Kikuyu really, that serves people from all corners of the country and East Africa, is like a semi-autonomous unit led by their director of clinical services or the unit manager, who is a consultant in their own right. The general hospital side, which is where you'll meet pediatric, medicine, surgery, obstetrics, ICU, renal, MRI, CT, ISO-certified lab, everything, accident and emergency, funeral home, kila kitu. They have their own director of clinical services or the unit manager, who is a full-time consultant by their own right. Then the dental unit with its own, then the rehab or the orthopedic unit, which is the center for bone and joint and spine problems. Each of these units led by their own consultants. The 4 units, the unit managers report to the CMO or the chief medical officer, and then director of nursing. So that gamut of the medical division is what I direct or I lead. And then, of course, we have the School of Nursing, which has 100% pass rate on the Nursing Council. And then we have a branch in Matasia called PCEA Matasia Satellite Clinic, PCEA Kikuyu Hospital Matasia Satellite Clinic in Matasia Ngong. So now the other administrative, the finance, the HRM, the procurement, and the Principal School of Nursing report to the CEO. And I report to the CEO. So essentially, that is more or less the coordination. So it's ISO certified, it's got all these achievements and the complexity in any organization that you can run. And yes, as you say, it's quite a busy institution.
So how is it being in such a position? Because it is my biased opinion. Yes. It might not be very accurate, but it is my biased opinion that when it comes to medicine, sometimes, especially in the public sector, we're a bit shy when it comes to leadership. Do you agree with that?
No, leadership is first and foremost. Maybe it's leadership and management, or it's management first, because management means you have taken up a duty that has certain deliverables, etc. But leadership is there and is situational. So even if you went to a public facility and you had a team, you would quickly suss out a leader and say that's the team leading that, just by how they carry themselves or by how they have been exposed. So there's an attitude aspect, there's a personality aspect, and then the exposure and the training. So maybe what you're referring to is more of management. But it's okay, I will pick the leadership. I have constantly observed that sometimes the training in our medical school is we lay a lot of emphasis on the clinical because that is the heavy thing.
Yes.
And we think these others are more fast.
Yeah.
And my experience,
the management, all
those yes. In my experience, when I was training, the curriculum was very good because we had the foundation. We used to call them IRD courses, Institute of Human Resource Development, because that's where they would come through. So we had communication skills, writing skills, library skills. We were taught how to write. We were taught how to reference. We were supposed how to search literature online, but physically. You remember the cards? How to search for the book. Because if this Library of Congress, how are they coded? Exactly. Like, surgery is R. And RD is surgery, or RD is therapeutics and pharmacy. You know what I mean. And then as we went up now, you had quantitative skills, the accounts, the bookkeeping and all that. And then we had what we called health services management, which was a whole 6 weeks course. But the way they were packaged, if I was to give advice in hindsight, you would bring this thing after people have finished everything and sat their final exam before they leave. Because now you are certain there is nothing preventing you from going. Exactly. But you are told before you graduate, there's a mandatory module. So you do this. So then you're able to know how to write. Of course, writing and reading skills, you need them as you come. Those are okay. But things around quantitative skills, accounts and finance and entrepreneurship and healthcare management should have come at a very senior position, probably the final year. So that you leave as you go to internship, You already know what is district health management team, what is hospital health management team. But those are things I learned earlier, and I'm expecting to keep that knowledge.
Exactly.
If you're not using
it,
if it's not
it will disappear.
situational, I will forget it.
True.
But this other thing you teach me, and I see it in the word, so it
sticks.
reinforces. It reinforces, and I remember. So yes, you can say that about the training. And the other thing also, especially if you see is whole of the some sunk cost kind of thinking. All those years, all those sleepless nights. How can I now abandon surgery? I can't. I have already invested too much. I feel that's what we have. And even in my space, for instance, unless in the public sector where you will say the med soup is always a clinical consultant, in the rest of the private sector, the faith-based space, because you invest a lot of energy, you feel like I wasn't made for this. This is not my strong point. Let me just go run my list. Man, I'm in my element when I'm mobilizing that loop of the colon. I'm in my element when I'm taking that pedicle. I'm in my element when I'm picking that diagnosis when everyone has missed it. When I'm telling them, no, don't bring the CT. I'm okay here. That's where you want to drive. So no one wants to take the C-suit because you now have to go around reminding people to do their things. And
which is not...
When most of the people are not as forthright, and most of the people, the knowledge level might be different. Sorry to sound demeaning, but you will still have to go talk to a different kind of a person, and you might have to tone down your communication so that it's very clear for that level, and you might have to supervise and tell them, do as I watch. No, go back, do again. And then you have again to come and titrate this, and to a consultant, you just need to, just tweak them a little and say, let's touch base. You give me your experience of how it went. So it's quite something to ask of someone unless they really want to volunteer. And if you come to the C-suite at the moment, you might not meet many clinical consultants. I mean, they are handful. They are handful. Most of the medical directors probably are MBCHB and the MBA.
Exactly.
And they moved on. But then for me, I feel, of course, a time will come and you say, you know what, I've done my season, let me retreat to the theater. Because that's me. That's what everyone has, that's what the state has invested billions and billions and billions.
But then the management aspect, I think, is very important.
I agree with you. And I am of this school of thought. Some people have a school of thought that if you have a good manager, then they just need the technical feedback from you to execute for you. I am of the school of thought that if I am in that boardroom, there is something that might be missed in the reports, in the spreadsheets, in the run charts, in all those presentations, in the minutes, in everything, that I can put to perspective based on
your experience.
Front line interaction with the client. When the client come and see me tomorrow in the surgical unit, very few of them will know I'm as chief medical officer. They will just talk to me as the consultant. And when I see them, I see the frustration they have gone through to get registered. So I know how they have gotten lost as they took the corner. I will know how they have taken long for the lab to come, because I'm the one calling the lab and they're telling me, oh, we missed that one. Let us rectify. So when they bring me, bring me the report, I also have some raw data and raw experience, and I tell them, but this is not my experience. So management is always extremely blind-sighted. There is a common mention that
they're out of touch with the people.
Exactly.
It's like our government.
We call it blind-sighting. That the senior management might actually understand only 4% of the reality on the front line. So I love that delicate balance. Is difficult, and I'm very private to the price I pay. The price I pay is, I'm not 100% in management, otherwise I will now be in Strathmore doing my MBA and DBA.
Which you haven't done.
Which I haven't done. Or I could be fully in surgery, and now I am finishing my fellowship in hepatobiliary. I've gone for all this radical stuff, and I'm doing all maneuvers and running for every case, because now when you come, I'm the big guy. But once in a while, someone has to start to study in that middle and try to, stabilize things.
I think that's, the way you describe it, I think that can actually bring a lot of sense and a lot of itafanya watu waelewe, because management sometimes you tell them this doesn't happen, this can't happen, and they're like, no, it has to be like this, because I've seen med subs even in public who are like, that's what I want and that is what is going to happen. But when now on the ground mnaumia, as doctors you can see patients are suffering because of those policies, and that person is out of touch. But I think this aspect of bridging, it is quite good.
Yeah, it can work. When you look at the health, the Health Act, the Health Bill 2015, it actually envisions that a level 5 facility, the medical superintendent is supposed to be a specialist. The medical director or medical
has to
superintendent has to be a medical specialist with this period of experience. At level 6, medical director has to be a consultant specialist in the clinical area with this kind of thing. But when you look at it, sometimes it's a pull, sometimes it's a push. So you advertise and I'm not interested. And because I don't want...
People don't like the politics of
I don't want the politics. I don't want to be accused, oh, you influence procurement. That time I have got no idea. You don't want to be accused, oh, my patient came and they were talked to badly, rudely by the guard. And you're like...
You're a senior surgeon.
Man, can you please bring my patient to theater? So I know that it is not an easy ask. It's just pushing yourself out of comfort zone, but also giving yourself a timeline. By the way, that's one of the things I write in my book, that if you have something you can't control, you yield control back by giving yourself a timeline. I call it the principle of the intestinal obstruction. We conserve intestinal obstruction for a period of time because we tell him either it opens by itself.
If it hasn't opened,
I have to operate. But at that time, there's actually nothing you are doing. You as a surgeon, you have not taken any control at all. It is controlling you.
Yeah, you've just given it the
time. But the control you have said is by reciting the mantra that you shall never let the sun set twice on a patient with bowel obstruction. So for 8 hours,
that's it.
It's not opened, we are going to theater. So sometimes you do that, you're like, those things I can't control, but I can actually control the things I can control, and I can control the time I allocate for myself to do this. After that, I will go elsewhere. After that, I will do something else. So I love doing that. I'm a disciple of Range. Range is a book I love. I haven't finished reading. I keep reading it and going back. It's an interesting book by David Epstein, and he talks about the curse of the specialist, because you can become so specialized. You have heard the rumor the joke by Atul Gawad that in the US you might hear there is a specialist for the left ear and another one for the right ear. Both of them are ENT surgeons, So you can get so specialized that you become binocular and you suffer the curse of, the proverb you hold of a hammer to whom everything looks like a nailhead. But the moment you expand your breadth, then you are quickly able to find out, here, by the way, I got a concept from my experience doing something else. So I also love I can see myself jumping into academia. So I have gone full circle clinical, then administration, then academia, then a clinician scientist. And then eventually I'm an all-round surgeon.
Are you particularly drawn to any of these things, any of these three major pathways?
I said I talk about my brand as sowing for impact. We started with that. Speaking, operating, and writing. And writing can take any scope. It can be research, it can be my books, it can be policy. So in fact, my position as I look at, and that is my drift now, is the space we call global surgery. And global surgery is that interface of the clinical work, the health system strengthening, the policy aspect, the advocacy aspect, the public health aspect, because there is a public health aspect of surgery. From the word go, I have been speaking to you about the health systems and policy strengthening aspect of surgery from the time I went to rural Kenya up to now. So that is the space, because that is the space, but it's not patronized. Every day, consultants will pile in my room with complaints that this is not working, this is not working, this is not working, isn't it? Patients will complain this is not working, this is not working, this is not working. So it's okay, we look at it like I can get into the theater and I can do a perfect job, But if the medicine is not available, then the patient will still get surgical site infection.
Exactly.
If the nursing care teams are not streamlined, the patient orders will not be adhered to, and the patient will complicate. So you need someone to tie all the dots with an aerial view, to tie all the dots, to get the system working, to get the system constantly working. And there's a specialty called global surgery in that. So I find myself in that area, that academia or what we call a clinician scientist, which is another space we need to empower a little more. Clinician scientist means, you see patients still, but you do a lot of research also. I mean, every so often, if you go to a journal club, a specialist will tell you there's a big trial going on in Italy, wait for that. Or there's a big trial in NIH going on, they are recruiting now at their third year. We are waiting for that result. These are things we should be doing. So you are recruiting and you are doing it actively, but you're not doing it completely detached. You actually run your clinic. You run a clinic today, you run a theater tomorrow. The day after that, you run your trials or you run your research or something like that. So at the end of the day, I will still be a jack of those three. And hopefully a master of several. I like to say that my ideal week will have 5 days, of course. 2 days clinical, 2 days either admin or research. And by admin or research, if you can do either of them, it means you're doing admin work in an institution that is a research institution, or you're doing some admin stroke research stroke teaching in an academic institution, like a university or a teaching hospital. Then I will have one day that purely is dedicated now, read, think, imagine, meditate, those things. Because that is also missing. Sometimes you run around, then when you go and live, you're like, why have I been struggling like this for a year? Why couldn't I just have done that? Because probably you don't have enough white space, and white space is important at certain level of thinking. So I don't know, I don't like to put myself in a halo jacket. But my PhD is in the field. My PhD, which I want to pursue, which I'm pursuing, I just need to get funding. Have you found someone to fund me? It's going to be in global surgery.
One can find you.
Yeah, please, Daktari Kikuyu, I will share my proposal. If I can just get tuition funding, tuition scholarship, and something to pay data recruitment people, I would be great. So it will be in that space.
Speaking of research and funding, it's one of the aspects that here at Daktari Kikuyu, we really try to look into. To try and mobilize, because I think research in this country is very underfunded, number one.
Yeah, absolutely. Absolutely.
That's why you find people in master's programs doing very, very demure researches. People just, very simple things just to pass, but then they have great ideas that they can implement, but they're like, I still need to pay school fees.
It's the Maslow's hierarchy.
So let me ask you, in Kikuyu, if you had a medical officer who wanted to do a research, a local one within the hospital, would the hospital fund?
So what we have is when I joined, we've established multiple clinical governance committees. One of them is the Institution Review and Ethics Committee, like the equivalent of IREC or IRB. And one of the mandates is to look at areas of research to initiate internal research from within the institution, while the other mandate is to review external requests for conducting research in the institution. And now that mandate is there, the committee is running with it, but individuals can actually look at research opportunities. I have a couple of your colleagues who are the medical officers level, and I've floated a couple of opportunities. Even interns, it has always been my behavior. Interns in surgery, when I get an idea, I tell them, okay, why don't you just gather this data, even just a retrospective series on this? There are papers written about WhatsApp groups for management of patients. I'm like, why don't you do this? And now, because you're all over the place and you're spreading yourself thin, you might not be able to concentrate. And you leave it at that. But yes, we have that capacity. We just need to develop it. We would not say we will fund, because at the moment, we don't have a budget because we just started. But this is something that can be brought forward and then it's put in the budgeting and say, for this committee, we want to allocate the members this much because we want them to do a training on responsible conduct of research, so that when they are reviewing the proposals, they know, are these proposals ethical? Is the methodology sound? Are the subjects protected? All those requirements. And then if someone wants to do this research, how do we fund them? So it would be easy if you can say funding, sometimes funding, people want to look at the cost aspect, but sometimes funding could be as much as requesting for an hour a week of the rota to concentrate on data research, collection. And then we do that and you request it and we approve, So I think for me, we want to start at the low level, and then the next level is really to make the institution also an extramural research center. And there are a lot of extramural means outside the body. like that Barata is extramural, is outside this room.
outside the lumen, like an
extramural. So extramural means if you have an institution like called Daktari, a quick one, and you want to conduct research, you can conduct here, but you can also come and conduct. No, extramural is not a surgical term. It's just an English term. Really? So you can get these institutions that are doing big research, and you can collaborate. You can be their peripheral research center if they want to research something. But what we also want to push ourselves, especially in the areas where we are really the pace setter, is to start slowly by setting the pace. We could have a fantastic registry, for instance, and now that we have a robust HMIS, in just to package it properly and work with a good person who can do proper system metadata aggregation and say, this is actually the Kikuyu registry on cornea perforations. This is the Kikuyu registry on cataract surgeries.
We do not have data.
Once you have that registry, you slowly become a center of excellence. And we know world over that the private sector sets the pace, then quickly the government comes and says, let's adopt this one. Otherwise, when we wait sometimes for the government, it might take some time, because or have the policy, but it's not implemented. So that is something we are keen to do, so that you are not just operating 40 surgeries a day in the eye unit every day in, day out. That data can be decanted in a way, and we can say we have a Kikuyu symposium on eye health every year, and this year we are sharing our series. This year we are sharing our series. Next year, the Ophthalmology Society guidelines will have the Kikuyu protocol on this, because you are pace setter in that. Then you come to orthopedic, complex joint, complex primaries. What is your consensus, or something like that. So we will push in that clinical governance, but you start by what surgically we say, tying your shoelaces, streamlining things first, like training, internship is okay, training is okay, all clinical governance committees are okay. Now we start punching upwards. But our Vision 2050 is very strategic to be able to really integrate AI and technology and all that and push ourselves. Yes, we have a Vision 2050 and we have a strategic plan 2023-2028.
Amazing. Speaking of pace setting, as we try to conclude, you've worked mostly in mission hospitals.
Yeah.
And I can say mission hospitals in this country are amazing. Okay, some of them. I mean, talk of Kijabe, talk of Kikuyu, talk of Tenwek. Those are pace setters in real sense. What do you think sets them out? What makes them like that? Is it the faith aspect? Is it what is it that makes them like that, as opposed to maybe some privates, which we see maybe some privates come, they grow, and they collapse.
Very good.
Or publics where patient care is suboptimal. What do you think is there?
So each institution can answer by their own, but because now I have been in 2 Catholic mission hospitals and now I am in a Presbyterian mission hospital, the one convergence thing I see is that you have to have something higher. You have to have a vision, or you have to have a higher vision or a higher mission. So most of the mission hospitals, the mission will be to do some mission, so that you are treating as part of evangelism, you are treating as part of spreading the gospel and all that. So you have to have something higher, so that it is not always the bottom line. And therefore you are making sure the institution remains financially afloat, so that you can advance Christ healing through the treating that you are doing. Now, let me come back to why I have worked in the mission hospital, and that might answer. When I was in undergraduate, for my elective, I went to Sweden. We had a program. We had a program where the top performance in the class would get a scholarship to go to various
for exchange program.
Western universities. So I had some guys go to the US, North America, and I went to Sweden. I went there when I had not come to the work environment, especially in the private sector in Nairobi, to see all these doors that are keyless entry, all those things. You approach the door, it opens for you. So I was really amused. But I saw a healthcare system that was working and it was public. But the guys are heavily taxed. But then they don't have Gen Z protests. Guys pay like 55%, PYE, depending on the bird of your income. But But education is free up to the university.
That is the point.
Health is free. And when you are discharged, there is a taxi that picks you and takes you to your home.
Yeah, not just taxing for the sake of it.
Yes, not taxing. The taxi is away. Anyhow, so when I came back, I was like, wow, that's quite something. Then I went to a public hospital for my district hospital attachment. For my district hospital attachment. I don't want to mention because if I mention, I might be sued for character assassination. But this is what I meant. You go, a patient comes, they have to buy a cannula outside because it's a stock out. They have to buy a cannula outside. And because I'm a medical student and there is a dehydrated child, if I take that cannula and try to cannulate and it tissues, I look at the patient and I look at the relative as they have tears down their eyes and they have to go outside buy another one. We would prepare a theater list and a patient is told, the surgeon who will scrub tomorrow will wear 2 pairs of size 8 gloves. Go buy. Come with 5 liters of normoxidine. So patients would be brought to the receiving area with a bucket full of these consumables. And I said, I am not boarding. So by the time I was finishing, I was very clear that I want 2 things. I want a modicum of efficiency and order, but I also don't want to be a clerk. And I know you have had that experience where you come, you talk a little to the patient, and then you can't touch the patient anymore because the patient is fussy and they want to see the professor. Can I see your, how many of such have you done? You know your problems.
I know my problems.
Gen Z. Now I decided where I have that meeting point between an high-end private facility where anything you want is available and this non-functional district hospital, it is the mission hospital. And I said, I am going to do my internship in a mission hospital. I did my internship in a mission hospital. Then I said, now I am done. I want to go to an institution of training where I will never open my mouth in a wardrobe with the phrase, in an ideal setting.
Oh, okay.
You remember how you used to start. Every time you asked, how will you manage this patient?
As students.
In an ideal setting, I would do
hemogram.
I didn't want to use that statement in my training ever again.
So you wanted to go to
because
the
that
setting.
one creates a dichotomy that there are patients who should be treated ideal, but for these ones, let's do this one. So I went to Aga Khan. Because anything I wanted in Aga Khan, it was there.
It's there.
It doesn't mean it doesn't have its own
it has
downsides,
but
because people
care.
can over-investigate. And our professor used to be very particular. It doesn't matter if the patient has a limit of $1 million in their card. At the end of the day, there is someone paying that money. Don't just make quality healthcare expensive. Expensive healthcare is not quality healthcare. We talk about equity and efficiency.
This is your professor in AKU?
Yes. So he used to tell us, you will take pride in your 10 fingers when you can arrive at a diagnosis, even if there's a PET scan, an MRI, and a CT, and you've not had to request it. Because why are you requesting it if you can have a diagnosis? So you'd have someone come with an MRI of the wrist because they have a ganglion cyst. I'm like, boss, that one, I just need my eye read with a ganglion cyst. And let's go, why did you spend 30,000 to do an MRI of the wrist with a ganglion cyst?
To make money for the hospital.
So now, I did that, and I finished. And I said, but the real patient of the Republic
is in the village.
In Kenya is in the village, is in the public hospital. But there is sometimes a frustration in the public hospital because everyone will say, serikali saidia. But when that guy comes with the obstructed inguinal hernia, and you are the person sent there by the government, you are the face of the government. So which other government are you asking for? So I decided probably I will still go back to the mission hospital, but that's where the job came quickly. So where my intentions were very clear for internship and for residency. And then after that is free market. So the one who came calling, I went to the mission hospital. But I love the mission hospital because if I am frustrated, I don't have to jump bureaucracy after bureaucracy to get to the person who is the decision maker. I can actually finish the clinic and walk to the CEO's office. Today, before I came for this podcast, I had a meeting with a consultant and they called and say, I need to see the CEO. CEO is on leave, so I was sitting for him. So I told him, come, let's talk. So the fact that the bureaucracy is not so tortuous. You can actually reach there and tell them, please do this.
I was talking to Dr. Milimu, one of the episodes. He's a med sup in a sub-county hospital.
Yes.
And the bureaucracy, he was telling me just to get something approved, meetings and all, it's a lot.
Yes.
It's a lot.
Absolutely.
So I understand what you mean. So you're saying that cutting short the bureaucracy helps things run.
So cutting short the bureaucracy helps. And number two, this guy is the mission serves those people because that is the brand. The brand has been, initially when they came, they were actually for free. And now you have to ask people to pay something slightly more than the government because you have to meet the payroll, you have to pay your creditors, your suppliers, you have to feed the patient, you have to buy medicine, everything.
And the government,
so they have to pay.
Does government support mission hospitals anymore?
Not in a strong way. A few of them will have a few seconded people, but not by way of exchequer release of some money. No. Why? Because the government, the health was devolved. So unless you have a mission hospital which is really in good terms with the county governor to tell them, let me second for you someone, we have those incidents, but they are isolated. So now mission hospitals have to exist in a robust environment where you are expected to offer top-notch care like a private hospital, but
at the cost of
people is almost asking you to pay to do it for free or at the cost of the public hospital. And that you are treated like that by the patient, you are treated like that by the government. But your staff want you to pay them because they are clocking in more hours, they are giving better care, etc. So it's that conundrum, it's that confusion. The solution is a working public health system. You cannot replace a public health system. You just have to make it working so that the private, whether they are faith-based or privately owned, complement. Even in the best of the public systems, look at the NHS. You go there with a gallbladder stone. They look at the waiting list and tell you, elective gallbladder surgery, come next year in January.
6 months.
You might have 9 months. There are some trusts that have a whole year waiting list.
And this is the UK.
If it's elective, but it's fully paid for. And the moment now it complicates, it becomes an emergency. You will be admitted, everything will be done, you will go home. Even there are a few private facilities for that person who says, I'm not waiting for those long, let me go. So there is a lot that can happen in the public sector without messing up the private sector because we're there to complement and to support.
Amen. That is the word of the day. Public sector. We need to revamp it.
It has to. There's no way out. It has to.
A quick one,
Yes, Daktari, a quick one.
Would you take up a role in a public setting?
A quick one, Which role?
As a leader, as a management, top of the food chain.
So what happens nowadays is you don't say yes or no. You remember what we read Ken Walubora and they used to say mtu akatai wito ukataa itiwalo. So you have to look at what is being offered vis-a-vis what is your career projection, what are your ethos, what does it stand for? There won't be career moves, there won't be moves in the public that are career suicide.
Let me give you a context. Career suicide. Let me give you a context. Very recently we marched and we said Nakumicha out and
Nakumicha must go.
Nakumicha must go.
Nakumicha went.
Nakumicha went.
Tukakamega, Pungoma.
I think is it Trans Nzoia?
Trans Nzoia.
And
Okay.
I'm not sure. Ama it's Bungoma, one of those. So if
In Tongareni.
yes, if Arutodi, okay, His Excellency, for respect,
Yes.
if he called you and told you, I know you're doing this at Kikuyu, but would you be interested in this position at as matters were at that time? So there's strikes, people are complaining, health's devolved, everybody is not satisfied. Would you take it? Or it will be career suicide?
No, I think I would. I think I would because, look, we say the man in the arena. There's a famous quote by one of the US presidents. I think it was Theodore Roosevelt, who spoke about the man in the arena. So sometimes we complain a lot.
Yeah.
But the moment we are told, okay, you are complaining, come, who wants? Everyone chickens out.
Yeah.
So I am usually of the opinion is the men in the arena is the one. They are the ones who know when they have won, the sweat they have sweat. They know the heat they have withstood in the kitchen. When they lose, they are the ones who come with the experience of what worked, what didn't work, and they come the better. So I am not one to say, no, I don't want. I am one to say, okay, fine. So let me come. I will have very clear, my colleague in HR calls them very clear output metrics, very clear outcome metrics. And then we say, can we work within this arrangement? Is this something that can work? If it's not something that can work, then leave it. Because also it's not necessary for you to be there and keep saying, okay, yes, sir. Yes, no. At this moment, you just need to say, this is my opinion. How would you have it? I don't agree with
They
it.
take it or they leave it.
Or I agree with it. Or I agree differently. And what you learn really in management and in big institutions is everyone is always for the establishment. Only their perspectives differ. So you want to say, pay the doctors $1 million. That is the best for this industry. Then this other person is like, build big ultra-modern buildings with non-carcinogenic wheelbarrows. That is their perspective. So you just need to manage the perspectives to answer shared direction. That is why strategic documents exist. You know, there's a vision 2030, there is a strategic plan,
So you bring all
there is
those
a county
together.
integrated development plan. So you are able to harness in a certain way. Otherwise, anyone can always go anywhere. If you don't have a direction, anywhere is your destination. That's what happened to Bartholomew Diaz. He decided he was going to come to India. When he got to Cape, if I'm not wrong with my history, their compass malfunctioned and the monsoon winds did not turn northeast. So they went to Americas and then they discovered America. Then they said, we met red Indians. They didn't say we got lost.
Yeah.
So essentially those documents exist to do that. And of course you come with humility and first of all you learn. First of all you have to learn, okay, so what manpower do I have? How do I align them? Because really at a certain point of view, you are not the one coming to bring the expertise. The expertise is already there. Yeah, you know, as Steve Jobs told Wozniak, I don't have to be the best instrumentalist. I am the best conductor. So your work is really to conduct the orchestra. You know, this guy is strong in this, run with this. This guy is strong in that, run with that. Then this is our reporting mechanism, this is how we go, and then, you know, vision together, journey together, motivate teams and all that. So any opportunity that comes, we should be able to do that. I was trying to run away from the public because with devolution, as a consultant in the public sector, really you have no career trajectory. You are just there, and the next sub-county hospital, you will be sent there where there's only a CS set. And you are there and you want to do laparoscopy and you're like, so what have I come to do? Because initially when it was at the MOH, you could grow in the job grade, become senior assistant director of medical services, assistant director of medical services, deputy director of medical services, found yourself in MOH. It was very easy. But in the county, you are a blue collar worker. Highly skilled.
I call it a red collar job.
Oh, now it has come red because of the blood.
Because of the blood. That's just mine.
I see.
Amazing. Okay, we've taken a lot of time, but
you will pay.
I will pay for your time. Yeah, we will monetize and pay.
Yes, fix that one.
Send
to this number.
Number inapita hapo, hiyo ni ya pesa.
Yes.
So last thing,
yes,
to the young doctors, what would you advise us? Just one thing, because right now most of us are battling a lot of things. We are battling tough economic times.
Yes.
We're battling unemployment.
Yes.
We're battling toxic workplaces.
Yes, toxic seniors like me.
I hope you're not toxic. You don't sound toxic. But yeah, toxic seniors, people who just, bully you. And, bullying might have been there since time immemorial, but maybe we are softer people.
Yes.
But what would you advise the younger generation? The ones who are looking forward to following footsteps like your own?
Okay. I would tell them what Prof. Atuoli told us sometimes back when we were in medical school. Yes. And he told us not to confine ourselves to the straitjacket of the white coat. The white coat and the stethoscope. Because if you wind back the clock just before you joined medical school, you are the quintessential performer who could take any course in the university. You could take law, you could take engineering, you could take all arts, you could take BCom, you could take aviation,
anything.
Basically anything. The rest who are lower took those because they could never get to medicine.
Exactly.
And you got medicine. But then what a calamity. What a travesty that suddenly you can no longer think anything other than medicine. Whereas you are the top student in English. Whereas you are the top student in Kiswahili and Fasiki. Whereas you are the top student in history.
Even CRE.
Even CRE.
You can even become a pastor.
You can open a church. Omera bwana, and just preach about the religion and gallbladder, religion and trauma, how to heal,
And
which verse to read. I have not advocated for that. Nonetheless, I would say that just open your minds. What you're doing is fantastic. This is the space that, it wasn't something we spoke about then.
Yeah.
So I would say open your minds, pick whatever you can pick, be as broad as you can. And, you don't have to be confined to Kenya. You can fly. Someone said you could be here and the town you are in is 20 years behind the rest of the world. You could take a flight and go to another town that is 150 years ahead of the rest. And you can basically move your world. If you flew from today, if you flew today to Singapore, let's pick Singapore.
Yeah, the ones the government is always comparing us to.
You're like, where am I?
Exactly.
Like, no, where am I? These guys are living in the future. Or maybe some South Korean places, for instance. Or maybe even Dubai, a bustling, business metropolis. So one of the big advices I have had from one of the podcasts, it was an economic podcast, was that you can actually move, you can travel across time and be ahead of your colleagues, because that's where the economy is. That's where economy is better. Nowadays, with all these people are thinking, actually, I find myself subconsciously thinking, which are those countries which don't have income tax? Because if you flew there and got a job there, if you got your money, there is no zero, you won't pay any tax, So suddenly you have something remaining. So I think for me, I would just, open your mind and just consult people, get someone who can mentor you. Sometimes I think of course, we keep a lot to ourselves without sharing out. But when you share, you might hear another person is having another experience. They have gone through it and
that's the essence of this podcast, to share amongst ourselves, amongst medics, so that mtu asifeel ako peke yake. So thank you, Daktari.
Thank you.
Any parting shots?
Daktari, a quick one. The parting shot is never get to the point where you feel, I regret taking medicine. Never get to that point, because look at the rest of the disciplines. Long time ago, tamaking was known to them. So people will know you mostly slightly outside of what you know. Slightly outside of what you know, but how you present yourself, the attitude you have. So the networking and the being relatable and having those human attributes, I think, are now slowly over and over coming above just the technical paper. Exactly. Especially with the rise of artificial intelligence and all these
need to be more
technology,
than just a doctor.
You can replace everything, but this conversation, that warmth, the failures, the human fallibility, that softness, sometimes really is what is needed at the moment. When you can automate it, you can automate your lift. It will order itself to be serviced when the time is due. You can automate the meters. When the pipe bursts, they will note there is water coming out.
But the human touch can never be
But
automated.
that human touch you might not automate. So keep the human touch, work ethic. That is one thing that I feel is going down with the woke generation, especially. The work ethic is underappreciated. So really, you can't come and send a text and say, "I'm not coming for work. I have resigned." I mean, surely there is a better way to do. I'm not saying the doctors are doing that, but I'm saying it is actually happening.
Yeah.
Whereas previously you would have said, "Hey, I feel like I should leave. I will come, we discuss," or something like that. So there is a lot of, the work ethic, the good way of doing things, just the humanity. Like they say, people remember you for what you made them,
How you made them
how
feel.
you made them feel.
Yeah.
So that really goes a long way in building you. As you journey, you pick allies along the way. Right now, if I call you and tell you, refer me someone, I have a locum for an MO, you might not pick the guy who was top in your class. You won't. You might pick some guy who smiles with people,
Exactly.
who understands you. You won't pick the guy who understands his human rights. I am not coming. I am clocking at 8 and I will
leaving
clock
at
out at 5, even if the patient is vomiting and choking on it. There are certain things that you want. So I think that is what I've seen, like we might be losing along the way. And they play a big role. But never let anyone tell you made a mistake by pursuing MBCHP. No.
It reminded me of a question my co-host wanted me to ask you.
Who is a co-host?
She's called
I've not seen anyone here.
Called Dr. Liz. She's off today.
Allah.
But she wanted me to ask you this. Would you advise your children to take medicine, or anybody else for that matter?
Yeah, I wouldn't mind. I would just give them adequate advice on what needs to come. Luckily for them, they know now their father will meet them asleep.
Yeah.
They know in the morning probably will wake up very early and disappear before they have had their breakfast and they have had time to, chat and
So
all
they
that.
know what it entails.
They know that we might be there having a day out and then I'm called for an emergency.
Yeah.
So they already will have seen the experience. So mine will be, would you want to be like your dad? So that would be a very easy one. But my professor, when I was training, told me his daughter wanted to be a doctor and specifically wanted to be an oncologist. So what did he do? He linked up with one of the top oncologists and told her, "I want you to shadow that colleague for 2 weeks. Go wherever she goes. You only retire home when she's retiring." When the 2 weeks were over, it's like, I don't want to be a doctor. So I think sometimes you go to an area we don't know because what is glorified.
Yeah, exactly.
And I think even in this mainstream media, in the upcoming alternative media, it's time also to demonstrate the humanity of the doctor. No one expects that the doctor can be poor. No one expects that the doctor can have their own human difficulties. No one expects the doctor can be sick. These guys are like the superheroes. That's a creation of the media. They are human in their own rights. They have all their own human weaknesses and all that. So everyone having the true picture of what it calls to be in that position becomes the best advice, because you have seen it. Are you willing? Number 2 is have your mind open there. In my generation, and as I trained, really you couldn't stop one day and postpone and say, let me go look for another way, because where will you get food? Which home are you going to?
Exactly.
Maybe your relatives are even asking you, can you send us 1K from your help so that your brother can get some pocket money when they have gone for half term. But if you are coming from a well-to-do family that you can go back to your family and be fed and watered and clothed and sheltered, then you can actually pause and say, I'm not sure about this.
Yeah.
And it is okay.
It's okay.
It is okay to say, I'm not sure about this. What I know is that experience is never going to be at waste. And again, I will reference David Epstein's book, Range. You will understand how having all this sampling finally makes you that refined person. The moment you're like, it doesn't make sense like that because I was in this other medical school and we used to make it that way. And now you're in an engineering discussion or in some soccer thing, but you
don't,
transported some experience. It's basically being
From
more
everywhere.
lateral and more well-rounded. Yeah.
Amazing. I think we should call it a day. We could continue forever.
We call it a
but,
night.
Oh, it's a night. Yeah, so I think we can do this again. I mean, you're always welcome.
Yes.
To Daktari Kikuyu. It's been amazing.
Comment below.
Watch a comment, share, like, do all that. Daktari here is available in kunaitwaje Kikuyu?
PCEA Kikuyu Hospital.
PCEA Kikuyu. You feel free to consult with him.
Yeah, absolutely.
Yeah.
Thank you so much.
Otherwise, Daktari, thank you.
A quick one.
A quick one.
Let me take my water.
Adios, guys. See you next time.